So immunonutrition is very funny. It's a very funny language that people speak. In India, we are very famous with talking about immunonutrition, because if you feel cold, then you have ginger, you get lasun, you got garlic, you got so many things in India, which is all about immunonutrition. But I'm against using a certain type of so-called immunonutrition in my patients, all right? So, and I go by evidence, by what is there in the literature and what is published. Yeah, that one, right. So I come from Apollo Hospital, Navi Mumbai. Welcome everybody to our to Mumbai, and please, the weather is very bad right now, but otherwise it's a great place to have a good time. So the goals was, to take the skeptical, or rather a scientific look at the principles, presumptions, and propaganda in relation to immune modulating diets in critically ill patients. So I'm going to talk about that. Basically, everybody talks about three things. So they talk about glutamine, they talk about omega-3 fatty acids, and arginine. And let's look at the literature which is present. Glutamine. Depleted in critically ill, response to stress, all that has been spoken about. But 5 randomized trials, nearly 600 patients, no significant beneficial effect on mortality, infection, or hospital length of stay. Multiple RCTs, redox trial, all of them are saying the same. In fact, glutamine has increased the mortality at the 28 days. So, trials after trial and randomized trial are telling the same thing. Look at omega-3 fatty acids. Using fish oils, initially, they all said that it reduces the neutrophil recruitment, improves oxygenation, reduces need for ventilation, so on and so forth. But now, after 6 randomized trials, where all the additives and formulas which were used were evaluated, there was significant heterogeneities based on the method of infusion, whether it was continuous, or whether there was bolus ribitol. So data after data is suggesting the same thing. Multiple trials, multiple thing, whether we are using arginine, where arginine is very popular because there is a role of nitric oxide in inflammation. But finally, all these trials had nothing beneficial to offer, nothing beneficial. In fact, most of them offered that the standard claim was the length of the stay in the ICU is reduced. But if you look at the data carefully, all those patients who have died were also included in those trials. So that length of stay, if the patient is going to die in 2-3 days, those patients were also taken into those trials. So that was, there was a lot of there was a lot of problems in that data which was presented. A meta-analysis by Haaland et al., where he took 22 randomized trials, 2,500 patients, was published in 2001. Again, mortality was unaffected. Infections decreased, but overall, there was a trend to increased mortality by using it. So take a closer look at what you're doing, whether immunonutrition. The problem was everybody thought that it is a downstream effect. Everybody thought that it's a downstream cascade. You block one cascade and things settle. But it doesn't happen like that. There are multiple things. You block one, something else props up. So I think that the way it was used was probably wrong, and we have to relook at the whole idea about how we are using immunomodulators in this. Guidelines are crazy. Nobody actually knows the dose at which these immunomodulators have to be given. Nobody knows. It has been proved there is no role in critical ill patients. Maybe early, preoperatively, perioperatively, we do give nutrition, but still I'm not convinced about immunonutrition being the need of the hour. Possible. Now let's take a simple example, like resveratrol. Became very popular. As you know, it is for a Mediterranean diet, it's very good. So people started drinking loads and loads of wine and got a reason of having wine. Okay, so just because something is good does not mean that you have to use it. Take the publication from Nutrition. Again, Again, multiple publications I've put. But the last one which I want to mention is this lady, a very pretty lady, Kelly. She's published Immunonutrition in 2016, Benefit, Harm, or Neither. Okay? I think all of you should go through this article if you have not gone. What she did was a summary of the meta-analysis and systemic review. Nearly 16 meta-analysis and systemic review still does not recommend, ASPEN guidelines do not recommend routine use of immunomodulators. Conclusion, no consensus. In her article, she has mentioned that there is a difference and there is no standardization in the outcome of these patients. There is a problem. The numbers were too small. There was a lot of bias. Lot of investigators were sponsored. All right, so that became a big question mark on the whole trial itself. Now, this is my last slide, but before that, when we talk about Ayurveda and our own culture, we generally do not mix milk with fish. I think you can go back to your parents and ask them. We do not do that as a rule. We do not mix non-vegetarian with milk. There are a lot of things which Ayurveda, I actually had a slide which I quickly put in, but I could not put. There are a lot of things which are there. Here, we are trying to get things, trying to make a quick, rapid combination and giving it in bolus forms. We really do not know the effect. We need a larger study to understand the effect. Thank you.